Atopic Dermatitis by Alicia Sells. Atopic dermatitis is also known as eczema. It is defined as an itchy, inflammatory skin disorder that is characterized by poorly defined erythema with edema, vesicles, and weeping at the acute stage, and skin thickening or lichenification in the chronic stage. It is an immunoglobulin E mediated hypersensitivity disease that mostly begins in children. When a person has eczema and then develops asthma and allergic rhinitis or hay fever, it is a progression that some call the atopic march, and all three together are called the atopic triad. Incidence and prevalence. 10.7% of children under 18 have atopic dermatitis. More than half of children with atopic dermatitis develop asthma and allergies later in life. Atopic dermatitis has a prevalence of 25% to 35% in children. The 1-year prevalence of eczema in adults was 10.2%, and the prevalence of eczema with asthma and/or hay fever was 3.2%. The incidence and prevalence are continuing to rise in Western societies. There are many theories to explain this. One is an increased awareness, detection, and studies of the condition. Others claim that it is due to an increased exposure to irritants such as chemicals, fragrances, and pollution that is exacerbated by society's need for frequent bathing. Another theory is the hygiene hypothesis by David Strachan, which states that the increase in eczema is due to a decreased exposure to infections and a cleaner environment that is found in Western countries. More studies are pending. Cause, risk factor, and clinical significance. The etiology of eczema is still not completely understood. Heredity is thought to play a heavy role. It is probable that the interaction of genetic, chemical, and immunological abnormalities along with environmental irritants begin the inflammation process. A recent discovery shows that the T helper cells predominate in eczema that lead to overproduction of numerous cytokines, which in turn overproduce histamine. This overproduction also promotes B cell proliferation and increased serum and skin IgE. Risk factors is a family history of atopy, which is eczema, asthma, or allergic rhinitis, and a dysfunction of the FLG gene that produces proteins known as fligrin that are responsible for the barrier function of skin. The clinical significance of eczema is very hard to determine because eczema is a chronic illness with remission and flare-ups. Each patient also defines a flare-up differently, which makes data retrieval difficult. Due to the wide range of eczema, some patients might find relief by avoiding known irritants, while others have exacerbations no matter what they do. All in all, eczema has a negative impact on the quality of life to all those that suffer from it. Clinical manifestations. Cardinal features are dry skin and intense itching caused by skin sensitivity to a variety of factors including allergies, irritants, stress, humidity, pollution, and infection. The area affected and lesions depend on age and vary from person to person. The infantile stage is from infancy to 2 years old. It is noted that the infants have pruritic, red, scaly, and crusty lesions on cheeks and scalp and sometimes diaper area. The childhood stage is from 2 to 12 years old. Lichenified plaques and bends of elbows and knees and in the volar aspects of wrists, ankles, and neck are noted. In the adult stage, you will find thickened skin with increased lichenification and excoriated and fibrotic papules found on the neck, bends of elbows and knees, face, wrists, and forearms. Of interest, people who no longer have eczema in the places they had it when they were a child are at an increased risk to have it on their hands and feet. Diagnosis is based on history, morphology, and clinical signs. Patient must have pruritic skin and at least 3 or more of the following: history of skin crease involvement, history of asthma or hay fever, presence of dry skin within the last year, symptoms that began in childhood, or visual dermatitis. People with eczema have an increased IgE, elevated interleukin 4, elevated eosinophils, and positive skin tests for several food and environmental allergies, but these are not used to diagnose. Skin biopsy and laboratory testing, including IgE levels, are not used routinely in the evaluation of patients with suspected atopic dermatitis and are not recommended. However, in selected patients, histologic examination of a skin biopsy or other laboratory tests may be helpful to rule out other skin conditions such as allergic or irritant contact dermatitis, psoriasis, scabies, drug reactions, primary immunodeficiencies including Wiskott-Aldrich syndrome and hyperimmunoglobulin E syndrome, nutritional deficiencies, Netherton syndrome, cutaneous T-cell lymphoma, and other causes. Medications that treat the symptoms are antihistamines. They are noted to be helpful with itching associated with atopic dermatitis due to blocking histamine and the sedation effect. Topical steroids are used to treat the condition. The potency of steroids depends upon the severity of atopic dermatitis. But due to the adverse side effects of long-term use of corticosteroids, a topical calcineurin inhibitor can also be used on more sensitive areas of the face, eyelids, and neck. When all else has failed, a systemic immunosuppressant treatment is used, such as oral cyclosporin that can be taken for up to 1 year. Therapies. Treatment of eczema targets the underlying abnormalities of the skin such as dryness, itching, infection, and inflammation. Education is the most important therapy, and included is the cause of the disorder, treatments, medications, and how to avoid flare-ups. Management of atopic dermatitis includes avoiding exacerbation by not excessively bathing, vigilant moisturizing, optimal low humidity environment, avoiding stress, and limiting exposure to fragrances. Maintaining skin hydration with thick lotions that contain little to no water content are highly recommended. A medical intervention that is used is ultraviolet light therapy. Complementary and non-traditional therapies. According to the National Eczema Association, there are several alternative therapies that people who suffer from eczema find relief with. These include hypnosis, acupuncture, traditional Chinese herbs, use of natural therapies such as sunflower seed oil, coconut oil, supplemental vitamin D, and topical vitamin B12. Some patients have also seen results from probiotics and dietary supplements such as vitamins, fish oil, and essential fatty acids, but study of effectiveness have been inconclusive. Goal of therapy: to reduce the symptoms of inflammation and itching, prevent exacerbations, and minimize complications and reduce adverse side effects to medications. Complications: The most common complication in atopic dermatitis is bacterial infection due to the defective skin barrier, decreased antimicrobial peptides, and the reduction of the immune system from the use of corticosteroids. In studies, Staphylococcus aureus was found colonized in over 90% of atopic dermatitis skin lesions. 16% of children with eczema have had a case of MRSA. Atopic dermatitis lesions can also have fungal infections such as tinea pedis or tinea facie. A serious complication that can arise is a viral infection of eczema herpeticum, also called Kaposi's varicella-form eruption. It is a rapid spreading of herpes simplex virus in the affected areas. The complication is rare, affecting only 3% of those with atopic dermatitis. Eczema herpeticum can have serious complications of meningitis and encephalitis, but usually responds well to antiviral treatment. Prognosis. Atopic dermatitis is a chronic disease with flare-ups and remissions. 60% of childhood cases improve by adolescent years, but the other 40% have a lifetime of discomfort ahead of them. It is estimated that 30 to 60% will develop asthma and 35 to 66% will develop allergic rhinitis. The American Academy of Dermatology states that there is no way to know if atopic dermatitis will go away or be a lifetime disease. They emphasize treatment to stop it from getting worse and skin maintenance to prevent flare-ups and relieve discomfort. Nursing interventions. The best thing a nurse can do for a patient with atopic dermatitis is teach. Educate about consistent use of emollient, types of medication, side effect of medications, environmental triggers, dietary triggers, information about complications and how to recognize bacterial or fungal infections. The Journal of the American Academy of Dermatology states that avoiding flare-ups by using moisturizers is integral to all eczema patients, and some patients may need a proactive intermittent regime of topical corticosteroids or topical calcineurin inhibitors to prevent flare-ups. They also recommend education intervention by way of teaching for an increased understanding of the disease, therapies, and goals of management. Goals. Eczema is a chronic condition. There is no cure. With treatment, the disease can be managed. Treatment's goals are to reduce the symptoms of itching and inflammation of the skin, prevent flare-ups from occurring by using a skin protection regimen, and minimize the risk of treatments. Other goals are to heal the affected skin and keep it healthy, as well as identifying and avoiding known triggers. Thank you very much. I hope that you guys enjoyed my presentation on atopic dermatitis and learned something that you can pass on to your patients.